Okay, recording finally worked. We just start a few minutes late. Okay. Hello, everyone. Welcome to the show. I'm your host, Ernie de los Santos, founder and faculty chair at Appeal Academy and creator of Top Gun Audit School. So we are live on the January 29th, 2015 edition of Finally Friday. I'm sorry, the 2016 edition of Finally Friday. Who wrote this script? Anyway, I want to thank you for choosing to spend your time with us here on Finally Friday. Today's Finally Friday broadcast is sponsored by the Health Law Partners, providing solid advice and real solutions for healthcare business nationwide, and also by Recovery Analytics. That's Sharon Easterling's company, my co-host, and she is definitely committed to your success. You should go take a look at their sites. Finally Friday is also now sponsored by MedLinks Cost Containment. They are the makers of the Healthcare Audit Tracker. You should visit zerodenials.com today and see how they can help you track audits and let you enjoy your job again. Another sponsor is Aerolib Healthcare Solutions. They are a patient-centered total quality management consulting firm. They are the makers of the Physician Advisor's Guide DVD, which is now available on demand, as you can see on the screen. We'll give you links to Aerolib a little later. And then finally, our other sponsor is the Council for Certification of Medical Auditors, the CCMA. They are the creators and the maintainers of the widely used Certified Medical Audit Specialist, or CMS, certification. You can see the link to their site right there. Okay, today we're going to talk about how short-stay audit rules keep changing, oh, what a surprise, and changing again. And to help us with all that, we have Dr. Ron Hirsch from Accretive Physician Advisor Services here to help go over an article that he recently published at RAC Monitor. And we'll talk about that in a few minutes. And then we're also going to hear about what I call the latest Medicare Advantage Plan appeals adventures of Dr. Larry Field, who is the Chief Medical Officer at Monroe Regional Medical Center in Florida. We also have Chris Baggett with us. He is the CEO of MedLinks. He's got a few things to comment about on the things on the show today. And I didn't get to add him to the slide. Sorry, Chris. Anyway, listen, I also wanted to talk about all these drug price control plans that are being bandied about. Well, all of them. There's one being bandied about by some of the presidential candidates. And I'm, wanting to talk about, is it really very different than what already happens with hospitals who are trying to rein in their costs? And what does all that mean for other things besides drugs and medical devices? So anyway, I do have my loyal and faithful co-host on hand, Sharon Easterling, who is an auditor, speaker, and appeal writer. Bill Mom is usually with us. He's a practicing clinician, speaker, and certified medical auditor, but he's unable to join us today. So thanks to everybody for joining me, and I do want to make clear that the opinions shared on this show are those of the panelists, and not necessarily representative of their employers or companies. And my opinions are definitely my own and no one else's, and especially not those of my sponsors. So now, before we get started, we have a good number of people on today, and we may have a number of people who are pretty new, so I want to bring up the website, and I want to show you where you can find the controls for the room in case you're not used to using this particular room. They're easy to find. They're on the right side of every page at appealacademy.com. If you scroll down, you can always find this box with the green buttons. When you click on that, it brings you to a page that gives you the meeting controls overview. Okay? And as you can see, and as you may have seen in some of the slides before the show, there are some buttons on this control panel that you have on your screen. If you're watching this, you have the control panel. There's information on how to connect to audio by either the phone or the internet. Internet usually takes a download, so we recommend, particularly people in hospitals, that you use the phone because that's a lot easier. There's also a chat box. We highly recommend you open that because sometimes there's an entirely different conversation going on in the chat box. And just so you know, that is not recorded. The video of the show is recorded, but the chat box is not. So that's not discoverable or anything like that. There is a way for you to zoom in and out of the screen if you want to. If I'm not zoomed in enough on something, you can do that all by yourself. I just warn you that once you zoom in, you have to zoom back out or it stays at that zoom level. There's a participants list. You're usually the one at the very top of the list. If you point at you in that box, you'll get a little dialogue come up on the side of it that lets you change your name. Now, you can do that or not. Some people put in their full name, put in a first name. You can do whatever you want with that. But I do recommend, please, in the chat box, in the chat room, please keep it professional. It is public, and we have a lot of different kind of people on. So, no, I'm not going to give you control of the room. So, forget about the request controls business. Okay. Let me see. What did I miss here? If you haven't figured it out by now, we're kind of informal on this show. It's a discussion, not a lecture, so you should feel free to enter any questions that you have at any time in the chat box, and my co-hosts and guests will try to handle the questions and comments as best we can. We usually are able to answer everybody's questions or respond to their comments at the time we have. We do take an hour. We pretty much fill that, and sometimes we go a few minutes over. I'm trying to get better about that. Anyway. Okay, so let's go ahead and let me get back to the main site. I'm showing everybody. I keep trying to get you. I can't play it on the show, but my Finally Friday theme song is available if anybody wants to listen to it. It's kind of an anthem, so break it out and let your revenue cycle staff listen to it. They'll enjoy it. Okay, back to the slideshow. And let's see what I have in mind here. It's funny, I just made the slideshow. I can hardly remember what's in it. Okay, last week on Finally Friday, we were talking about reform, and here's some of the topics that we went over. And that is available on the website, on Appeal Academy, under the Finally Friday past shows. So there's a recording of that and the handouts. And then this week, what we were talking about is, the idea that we wind up, don't you feel like you're chasing your tail with all these regulations because you go round and round and they make changes and changes. And then we're going to hear from Dr. Field about his further adventures with MA Plan appeals. And then we're going to talk about this, will the politicians really enact these plans that they have to control drug pricing by negotiations? And if so, what does that mean? So we'll talk a little bit about that. There'll be plenty to talk about. Some things in the news this week that I wanted to mention. Here is a famous celebrity complaint. Here's a famous celebrity, at least in our industry, is Marilyn Tavenner. Remember, she left CMS, in 2015, and she went to work for one of the Medicare Advantage payers. And so, then she comes out complaining that CMS is using these outdated systems instead of concentrating on something that is good for the beneficiaries. And my question is this, now you see that? Now you recognize it? So there's an article about what she's got to say about that. I find it kind of funny. So there's the link. There's a link on these. If you haven't seen us do this before, there's always a link to the original article at the bottom of the slides. So if you get the handouts, you can go find those. CMS had an open door forum this past week, another one of their marvelous education jobs where they sit down and tell us what's on their website or read us the regulation, and that's what they call education. At least that's how they report it to CMS as a wonderful education that they do for providers, and they don't understand why we don't get it. The weird thing about this one is they often do a transcript and a recording. Well, now they're getting pretty good about posting the recording right away. It was available a few hours after the conference, but then it's gone away. If you go there now, it's not there anymore. Well, good news is I recorded it, and you can find it. I posted it on the Aorta forum, and I will show you. I'll show you that in a little bit. But on the Aorta forum is a part of aerolib.com. It's a free forum. You register for it. You're not going to get on it. You're not going to get spam. You're not going to get on a big mailing list or anything. It's just so you keep out all of the people who spam forums like that. So anyway, there's great stuff on there, and I did put the recording there so you can go listen to it, or you can actually download the MP3 of the entire Open Door Forum. I don't know why they would not want it. Why do they do this if they're then later and they answer questions and then they don't want to be held accountable for it later? I don't know. So, excuse me. All right. So, we can get to some of the things that we said we were going to talk about in the show. That it does appear CMS may now be employing magicians, as Dr. Ron Hirsch he said these audits are marked by some sleight of hand. So now I'm going to shut up, but here's Dr. Hirsch to talk about this article. Do you want me to bring up the article, Dr. Hirsch?
Well, I think it's interesting to show the two tables that were in the article. Because I think that was the part that really irks everybody. Yeah. And if any of you have read it, you know that, there you go, when CMS first introduced the change to the BFCC QIOs, they released that top table, which clearly states for dates of admission October 1st, the QIOs will be conducting reviews. Well, when they re-released this on December 31st, suddenly the heading for that column went away. And that suddenly justified all of the audits they were doing from admissions back from May and June, from that the hospitals had no idea they were going to get. Now, someone did bring up the point, well, we should have been following the rule anyways, and that's true. But there was something about knowing that these are the admissions that really count, that I think some hospitals says, okay, we're going to wait till October 1st, then we're going to get real serious about this. So all those hospitals really got burnt because now all those admissions back to May. I also point out in the article that the wording about how far back they can look, one place it says date of admission, the other says date of, I think it's payment or billing, and those are different dates. Yeah. So it's just one of these things that just irks providers.
Do you think, Dr. Hirsch, because, with RACs depend on being able to have that look-back period because they're making so much money based on it. But I think the QIOs are paid differently, and I don't think it would be that – I don't think they would be, chomping at the bit to be able to reach back further. Do you think this is just CMS realizing they made a mistake on this, or did they decide to open it up more? What do you think?
Well, I don't know. It's a good question. I think they wanted to get the QIOs going, and so the only way to do that was to move the date.
Right.
But
meaning that they could look back. They could look back from 6 months prior to October 1st.
Right.
Yeah.
But Dr. Hirsch, it's Larry. I mean, weren't we looking at April 1st before they had problems with the RAC contract anyway? It was initially going to be April 1st. So when they moved this to, the QIO going to October, they actually slipped, gave us an extra month, so to speak. And I'm of the belief, too, we should have already been kind of following all this, that all these admissions matter, because if they go and find an irregularity, they can go back as long as they really want to. So really we needed to be doing this to begin with.
Yes. But I just think the fact that they made this change and they didn't highlight it, they didn't put it in red notes, say that it was different, it just kind of slipped in there, was just a little sneaky.
Yeah. And it was kind of, I think it's just, we've seen things like this before from CMS. It's like they've got so many departments up there doing so many different things. There's groups that think about it from a legal standpoint. There's groups that think about it from an audit standpoint or a financial standpoint, at least. Let's put it that way. And then another group that just, I don't know how they think about it. But there's groups up there I can't explain what they do or why they exist. And it seems like each one of them will issue rules or sub-regulatory guidance. And sometimes it seems like they don't talk to each other. So I tend to think that's what was happening here.
Yeah.
But it's more of this, and it happened on the Open Door Forum, and I know you were listening to it, Dr. Hirsch, because you got to ask a question on the Open Door Forum about Well, you asked something about. Oh, that's right.
Well,
it was very
about
timely.
the snowstorms.
Yeah, which I thought was a good question, just because it lets people think. Don't think that you can get CMS to okay somebody staying in the hospital because they couldn't get out of the hospital because of the snow.
Well,
it was pretty easy.
I really want to rub it in that they got to stay home from work, but hospitals couldn't just close. And don't hospitals deserve to get paid for the care that they provided because the government shut down the roads?
Very true.
In New York City, you were not allowed to drive. And, what can a hospital do? Just suck up the added expense. Yeah,
eat the cost. Or try to bill the beneficiary, but how many hospitals really want to do that?
Right.
So anyway, yeah. So that was, but it's like, somebody was telling them, made a very pointed comments that, look, you guys are making too many rule changes too fast. We can't keep up. We get a rule change, we try to figure out what it is, and by the time we get it figured out, well, then you change it. And there's no notice about that. There's no regularity to it. There's no rhyme or reason. So they were complaining about that to CMS. I thought that was great that CMS got to hear that. Not that I think that the people who were on the call are the ones who need to hear it, but so anyway.
Well, that was the other question, which again had to do with the training of the QIOs. They really changed the rule to add this judgment piece for, if you're not going to stay the 2 midnights, which is a very nebulous area that we've all kind of talked about before. Yes. And the QIOs were supposed to get trained, and lo and behold, they answered who did the training, which was the MACs. And at least in our MAC, they weren't really up to speed on knowing what the 2 midnight rule was to begin with. When we did our probe and educate, they actually ended up getting the rules wrong when we questioned them, so we'd end up winning the probe and educate cases during the probe and educate period. So we had the MAC, who really wasn't fully up to speed, training the QIOs and then providing them examples of when it would be okay for a physician to say, oh, this one's sick enough to be in the hospital even though they're only going to be there for a night, and then never share the same examples to the provider community. And the interesting part to be a reviewer for the QIO, you need to be in practice. This isn't your specialty to know fully what the 2 midnight rule is. You're not a physician advisor. You're still out in active practice. So you're taking people that are used to doing really good quality reviews, and a good process for that, and all of a sudden dumping this other stuff on them and then not sharing any of that information transparently with the provider community to know what this new exception sort of is. And for them to admit it that, no, we really haven't educated, it's kind of bizarre.
Yeah. Well, it just kind of speaks to, again, the problem that I think the folks at CMS face is it's really not a well-coordinated, set of rules, and they've got a lot of groups that aren't connected with each other. And I know the QIOs and the quicks, even the quicks wanted to do education, but I don't know that they're any better at it than the MACs were. And still, I think it's just it's a feature of the whole thing that it's confusing. They're trying to make something that is a qualitative judgment. They're trying to make it into a quantitative judgment, and they just can't do that. Medical necessity is not quantitative.
Hey, Dr. Hirsch, through all your contacts across the country, the different QIOs, did anybody, fill you in on the training they had for the new exception?
Nope. They wouldn't talk.
So it's a black hole.
Yes.
Wow.
Yeah.
Wow. They wouldn't talk to you about how they got trained, or they wouldn't talk to you about what their rules are.
Either one. I mean, they're using the same general guidelines that CMS gave out, and but they won't say what more that they received that we can't see.
Well, okay.
Yeah, and I really can't explain why you wouldn't share, 100 examples of cases where these would be appropriate for a midnight, just one midnight, because the provider felt they were sick enough. I mean, you should be able to share all those examples transparently if you're truly engaged in wanting everyone to do this correctly.
Yeah.
I'll take 5. 2.
I'd like 100 because at least you can develop a heck of a trend. 5 is tough.
Yeah.
All right. Well, this leads right into the next slide I was going to bring up, which was about the Dr. Hirsch posted this on the RAC Relief Group and brought it to everybody's attention. This NBC station that posted a story on observation. And, here were the questions that Dr. Hirsch had posted on the RAC Relief group, about this story. So basically this was a guy who was charged, because he was under observation. He went to a sniff, correct? Do I remember that right?
Yeah. Yeah.
And he got charged for it because he didn't have a 3-day inpatient stay before that, and he didn't understand that. So he got a $7,700 bill, and he appealed it. I guess he appealed it, and it didn't go through. It was denied. And so then, Dr. Hirsch, just explain your thinking there and your questions, and then I've got something from Dave Esquiza I'm going to bring up.
Yeah. So, Connecticut is one of the states that has a mandatory observation notice law in place. So we don't know exactly when this happened. We have to assume it was pretty recent. They just did a story about it. So the guy should have gotten an observation notice. And that clearly spells out that he's in outpatient with observation at these days. Most of the states say it doesn't count towards your nursing home stay. So that's the first thing. So, and then he was never told he was an inpatient. Then what's he doing in the hospital for 5 days? If it's
and why isn't he an inpatient? If he was there for 5 days, why didn't they make him an inpatient?
Exactly. Unless it was a convenience, they were keeping him, as because they couldn't find a nursing home, his family was out of town, whatever it was, and so he should have been admitted if he needed to be there.
All right, so here is, there was a post made by Dave Esquiza that answered back about that, and I'm try to bring that over here. If I can get this to cooperate. Because what it, here we go. Come on, move over. I don't want to change your size, I want to move you over. Okay, so here is a post by Dave Esquiza that she replied to Dr. Hirsch's post on RAC Relief. All right, let me zoom back out. That was too much. And she was saying, did the patient have a medical reason to be in the hospital the second midnight after the first? And they clearly outlined, the regs clearly outlined that you basically get a gift. But it's like you said, we don't know enough about it at this point to know. Well, was he there because there was medical necessity at least for observation? Because if there was, well, then you can convert them. And then apparently what happens is, this is what Day is saying that she cares, is the patient is getting better, so why convert to inpatient? You want to convert to inpatient because you can. It's a gift. That's part of the 2 midnight presumption and benchmark. And Day has a class about this on her website. This is one of the slides from it. And her website, here's her website that you can find. If you've never been there, you ought to go there and look at it. She's got a lot of free stuff on there as well. And this is one of the things that's on there. So, but it is a reasonable question. Why wasn't he converted if he was there for 5 days? So anyway, and this is the link. Go ahead.
Let's see, there's a couple in the chat box. I don't know if you're usually right on top of that.
Oh, shoot. Okay.
Couple things. Viewer 88 said something about a Hipaa violation. I'm not sure where they saw that. Viewer 115 commented, should we be posting cases that we think should be one-midnight inpatients? I'll give my opinion on that is that we should not, because what we think and what the auditors think may be totally different, and I don't want readers to think that we're giving, expert advice and guaranteeing that they're going to get admissions approved. So the first time we get formal indication of what should be, I could say an acute MI coming in Monday at 7 a.m., an ST elevation MI going to the cath lab who's perfectly stable and could go home the next day is a perfect example of a patient who should be inpatient or could be inpatient as an exception because they're high risk and they have a severe disease. But we don't know. So I don't want to give examples until CMS or somebody tells us what is a good case. And then
somebody
Daniels
was saying,
go ahead.
Go ahead.
I think Stephanie Daniels was giving a little bit of self-promotion, and she's absolutely right. the UR process at that hospital is, needs to be looked at. And I'm sure after it hit the news, they did look at their process.
Yeah, hopefully.
And she would be the perfect person to go in and fix it.
And there's somebody saying on the Open Door forum, they said something about reviewing 0.5% of cases for audit purposes. Was it 0.5% of inpatient or 0.5% of all MCR transactions?
All transactions.
Yeah, I think it's all transactions.
Yeah. So a patient walks in and has a CBC in the lab. That counts as a Medicare claim. That goes to your 0.5%.
Yeah. It will be, and I believe they did directly address that a little differently, but I agree with Dr. Hirsch. They're gonna add up all Medicare bills. So that's what they consider the universe, that they will take that 0.5% of cases. That's how they'll count it.
Well, I'd rather have them look at 1,000 CBCs than 1,000 DRGs. So.
Yeah.
Take all the CBCs you want.
Okay. Well, let's move over and talk a little bit about the Medicare Advantage Plan audits and denials. And some of you may wonder why I picked a picture of, did I really go look for a picture of somebody from Anonymous holding up a sign that says they're from the MA plan? Well, yes, I did, but I changed the text a little bit. So, but anyway, why did I use Anonymous? Because I think they're pretty much about causing trouble. So this was, Dr. Field, this was some stuff that you had posted on Rack Relief about 2 weeks ago. I actually showed this last week, but I wasn't, didn't get a chance to ask you to be on the show. But so can you tell us a little bit about this and what was happening? Because it's these, to me, it's like, come on, day 29, and so it's deemed preventable? Come on. It's kind of like they're doing it just because they can.
Well, that's part of the game, right? Particularly when you contract the RAC, that's the RAC's plan. So they don't pick up money unless they could find stuff. It's interesting when, my pet peeve on all the MA plans is these retro denials when you agree that, you present records to them, you both agree by contract or however you're doing it, and a person touched it, that these cases meet inpatient. The preventable stuff is very, very difficult to get into, especially when you look at this case. All the things were done that were appropriate. The patient was followed as an outpatient and all that kind of stuff. I don't know how you would prevent it when all the appropriate things were actually done. And then on the second case, what do you do with the non-compliant who doesn't show up for any of their stuff? You can call them 1,000,000 times. It doesn't mean they're going to go. And those are never preventable. The patient decides that they don't wish to do what you're asking them to do. And all of us, we all don't want someone to come in and say, here, we're going to take you everywhere and you have to go do that, then you more or less lose your right to self-determination, whether it's appropriate or inappropriate. You have the right to your own body and to do with it what you please. But why the hospital should be dinged for the patient doing this is just beyond belief to me.
Well, and that was a question I had last week that we talked a little bit about was, who should have to pay for this? To me, it seems like if the patient is non-compliant, doesn't want to do this stuff, and by that I mean not that they're not able to, but that they choose not to. Well, if they choose not to, then I believe that they ought to be responsible for paying for future admissions or care that is happening because they were non-compliant. I don't see why the provider should be the one who is held responsible for that. And I realize that there's a movement, or there's even logic to the idea that, well, perhaps the physicians should be more involved in making sure that the patients are complying or finding out why they're not. I don't know how to feel about that. There's a part of me that says you guys have enough to do, and there's another part of me that says, well, it kind of makes sense. But on the other hand, what about these ones that they just flat refuse? It's probably a small percentage, but who should have to pay for that? And at the moment, it seems like it will be the provider, not even the insurer. So let's see. Yeah, here's somebody commenting about this. How do you determine if a patient decides not to take their meds? Could this be patient educational level, learning, or disability? I think obviously those are some reasons why somebody may be quote unquote non-compliant. My question then is, or lack of money. What if they can't afford the meds? Who's responsible to figure that out? The way it's working now, it seems like the provider is going to be held responsible for that, regardless of the reason. Whether there's a good reason, a preventable reason, or not, the provider is held responsible and deemed, well, you could have prevented this. I don't think that's appropriate. Of course, that's me. And I'm not a physician, I'm not a hospital, certainly not a bureaucrat, but it just doesn't make any sense to me that the providers are the only ones who are going to be held accountable for that. I mean, does anybody else think that's or is there any? I don't see anything. And Sharon, I don't know if you were still with us. I know you had to be on another call.
Ernie, it reminds me the comments in the chat box and your comments. They remind me of the term, the fog of war. I mean, these are complex questions that you're posing and that other people are posing. When does someone decide to not do the right thing versus just don't understand what's occurring, don't know what's occurring, doesn't have the money to do it? And I think that it's one of the reasons for your show and everybody's involvement is like, do we really put the onus of that on one group? I think that's really the question, because trying to control individuals and how they comprehend and proceed is going to always be the human element is always going to be the intangible we can't get a handle on.
Yeah, so here's some comments in the box that's saying, who in the community should be making the determination that the patient was non-compliant? What about the medical homes concept, coordination with that, or with home health workers? See, that's still, and Mary's saying a lot of those patients perhaps wouldn't qualify for home health. And so there's lots of dials and levers here. John Paul Spencer commenting, chronic care management is supposed to be part of the equation, but the physicians can't get workflow together to do it meaningfully. Well, and I don't know about that. I don't know. I agree. That. And there's a lot of hoops to go through for the chronic care management that you have to meet, et cetera, et cetera. It adds a lot of bureaucratic
things within the office itself. So,
right.
Yes, there may be payment for it, but just because there's payment for it doesn't mean you want to do it. Look at all the people that, maybe would have thought a little differently about the EHRs if they realized meaningful use 1, meaningful use 2, and all the little hassles along the way, that maybe they would have done it on their own instead of asking for a handout from the government.
Yeah. And somebody was saying a patient has a right to refuse anything. I absolutely agree, of course. My point is that fine, you want to refuse it, that's fine, but you don't get to come back to the hospital 29 days later and get it, and get it paid for by somebody else because you refused. Refusing is different than not knowing or not able to. That's different. I think if you refuse to do it, I think you ought to be liable for the charges as a result of that.
Except you do get to do that. Except here, you do get to do that, and it's just, imagine trying to keep track of that, and how you quantify it. The fact is, you do get to do that. The question, I think, is how do we disperse the expense for people doing that?
Yeah. And here's a comment from viewer 181. Said, I just had one of our major payers tell me in our received meeting regarding denials, they had a meeting that they received regarding denials, that we need to separate medical issues from social needs, and they wouldn't address network adequacy for the needs that our patients have to prevent readmission. So if I understand that right, there, the payer is saying, yeah, you got to separate them. But did the payer say anything about, well, so if it's a social need, am I going to have to pay for that versus like a mental health issue?
Well, maybe this is a defect in the plans, because in reality, the patient has a contract with the plan. Patient doesn't have a contract with the hospital.
That's true.
The plan has a contract with the hospital. The patient's paying for their insurance to the plan. The plan picks up all the claims and all the rest of the information. The plan should know who their frequent flyers are and has the ability on a very large basis to do case management and all the other kind of things themselves. And they have burdened the hospitals with doing all this to begin with. So, that's a shift of burden in a lot of circumstances. It's different for people that, are totally uninsured, et cetera. Then as a community service, yes, the hospitals should be doing that to try and help the patients out, the community out, and obviously the hospital bottom line. But on the plans, that's part of what they put in for the HCCs and all the rest of the kind of stuff to pick up additional funds from the government for all these kind of patients. They have the capacity and the financial wherewithal, along with all the other type of infrastructure, to go out and take care of this stuff. They should not be shifting the burden to the facilities.
Yeah, see, and that's kind of the way I feel. My gut reaction to all this is that, wait a minute, the payer is the one who was collecting a lot of money. They've got plans in place that I realize the providers do get paid pretty well. I was just talking to my doctor visiting my doctor the other day, and I asked him about this. He said, well, the Medicare Advantage plan bonuses are sometimes pretty substantial. And I said, I understand that. That's one of the benefits of it from the provider's side. And if the provider is trying to get, if the payer is asking for the records to be able to justify those payments to the government, well, it seems to me the provider, should be willing to go along with that. On the other hand, there's the other side of that coin. They may come back to the provider and say, well, you didn't document it enough, so we're going to take your money back. I don't know if that means that they're giving the money back to the government. I think it just goes back to the plan. That's my impression. But somebody's asking for the source document about those ADR limits of 0.5%. I don't think there is a source document that indicates what they said on that recording. So you might just want to get that recording, find the piece in it where they say that, and keep that.
No. There's a document. There's a thing. Do you want me to email it to you, Ernie, and you can post it?
Yeah, and you can also, if you can put it in the chat box.
Oh.
Somebody was asking about it.
That's a good point. I'll do that. Okay. I just gotta find it online.
Okay, good. So I didn't know if there was one that pointed about the
yes.
limits, the amount being all the claims. Okay, great. All right. And so, John Paul, if you want to explain your point a little bit more, because I missed it. I know you're writing in the chat box and somebody appreciated what you wrote. I missed it, so I'm sorry. What else? Okay. And people in the chat box talking about their psych issues for some patients. And, yeah, I think it's pretty hard for healthcare providers to address many of those mental health issues. I mean, all you have to do is watch CNN's Dr. Drew to find out that there's an awful lot of mental health issues in the country that go unheeded and untreated and unrecognized. There's a lot of people that don't want to recognize them. Uses the people who are suffering from it. Okay, there, Dr. Hirsch put the link in the box that had that ADR limits document. I hope that's what viewer 115 was looking for. Okay, John Paul is saying that he was responding to Dr. Field's comments about chronic care management and challenges physician office workflows for the same. I just think it's difficult, period. That's what it seems like to me. And again, because you've got so many independent people, independent offices, even if they work for a hospital, you've still got separate clinics and offices and physicians, and I think all that's going to be difficult. I don't think anybody's really that good at coordinating all this care yet. Isn't that what EMRs are supposed to do for us, right? Isn't that why we have EMRs? It's so that we can do all that. That ain't going to happen until interoperability happens, and I think it's going to be a long time for that, unless we go to a single payer system, which actually leads right into the next slide, which was these where there's two presidential candidates and one healthcare delusion, according to this article in Forbes, because they're saying basically, you know, and I was looking at it, reading it, and the big deal is that, let me get my pointer back, is that, you know, Donald Trump had one thing to say, that, you know, he's gonna make a single payer plan. Everybody can have their doctors, their plans, they can have everything, which means, of course, he doesn't know what he's talking about, which is not surprising. I mean, he did the same thing over at Liberty University, the evangelical school. He couldn't name a favorite Bible verse. He didn't really know the difference between liking the Old Testament versus the New. Anyway, okay, I quit that. I'm not going to bash him anymore. Anyway, okay, but he's thinking about this plan that involves them being able to negotiate, the single payer being able to negotiate everything from the device providers and everything. And Hillary Clinton has a similar idea, and she tweeted, and that's what's shown in that article there, there's no excuse for letting greed get in the way of people's health, which is a nice idea, and I do think that the payers should be kind of ashamed of that kind of thing. And then there was one other politician I was waiting to hear from, Sarah Palin, but of course I'm waiting for her to finish her sentence before I can quote it here. So, but this whole idea, I mean, it does raise some interesting questions, doesn't it? The idea of, you know, what would these negotiations do? There's a link to that article about it in Forbes. And then here is Dr. Steve Meyerson. I don't think he was able to join us today. I had asked if he could get here, but I don't think we got it. Yeah, John Paul Spencer is saying, yeah, it's going to be terrific. That's the typical thing that that Trump would say. So anyway, here is there's a post that was done by Dr. Meyerson yesterday, or day before, yesterday, talking about this same article. And so then here are the questions, that I came up with. It, can we continue to pay whatever it costs to get the best all the time? My point being that, if you're going to go into the hospital and you need to get a knee replaced, you want a budget knee or do you want the best knee? And how do the physicians talk about it? So I'm glad I've got physicians in. Dr. Field, tell me what you think. You're a CMO. You've got a hospital that you can't necessarily just deliver whatever it is. Some doctor, whether he's on your staff or not, or employed by you or not, says we want to get this particular knee. Don't you have? You're going to have concerns because number one, you're not going to get paid back the total cost of that. Especially if we're talking about Medicare, you're only going to get a percentage of that. So don't you have to have something in place? Go ahead.
The problem, I'm going to look at it a little differently. The problem for us is, we're on a price fix, right? We know what we're going to get, but we have to pick it up. But yet, the industries that supply us, go for rates of return that are, 20, 50, 100% of, cost. So if you have people trying to sell a doctor, toilet paper, it's always almost 100% higher than what you'd go if you go to Sam's. You have all the same thing when all of us are kind of independently bidding. In some aspects, if you said this is single payer and the government negotiates the price for the best hip, the best this or that, then in reality it probably would help. There's, good and bad to the mixture of all of it.
Yeah. The problem I see is that getting some people like these politicians involved, how could they possibly know or see it from the kind of viewpoint that a Dr. Field or Dr. Hirsch or Dr. Pahuja or Dr. Meyerson or any of you on the line would have? You're going to have a very different viewpoint of it because, for the most part, you're in the weeds, and those politicians are way up there at 30,000 feet, if not higher, looking at this. So it's kind of difficult when they look at it and they start saying, "Oh yeah, it's simple. It'll be terrific." And I question whether or not, it's like the drug pricing. If they negotiate the drugs, and the plan says, well, we're not going to approve the one drug, we want you to get this. That already happens, right, with generics? You get the generic. They don't want you to buy the brand name because that's 10 times as expensive as the generic. The medications I'm on, if I paid for them by the brand name, they're $30 a month, as opposed to get the generic, it's $4. So, but of course that's pretty much the same thing, right? Whereas some of these medications or some of these devices, is it appropriate for the physician to be able to say, I think the patient needs to have this, whereas the payer comes back and with a physician comes back, maybe even somebody who knows something about it, and says, well, we're not going to pay for that, we'll pay for this less expensive one. Is that appropriate or not? What do you think, Dr. Field? Is it reasonable or case by case?
The easiest one to go by is the cost of the hepatitis C treatment drug that's, killing us. We're participating in different ACOs, et cetera, and yet we're held responsible for the cost of that drug, and that is the standard of care. Patient has hep C, they get the drug if they meet all the guidelines.
Mm-hmm.
It costs $100,000 a year. What am I going to do as a physician to control that cost? I can't do anything about that.
Yeah.
So I'm going to put up a link to an article that's actually Health Affairs blog about pricing drugs based on their
utility,
their outcomes. And the Hep C drug is very expensive, but what it does is in 12 weeks it cures a potentially fatal disease.
Yeah.
So that's unfortunately a bad example because it's a drug that has great value. We can look at some of the chemotherapeutics that extend life by 3 weeks compared to much cheaper medications. Is that a good value? I mean, cancer gets a lot more publicity and sympathy than hepatitis C, but it's a terrible value for the money for a lot of these things.
Yeah.
And I talked to Ernie a little bit about this morning. I mean, this is really an ongoing battle because you have, you're trying to do supply management within a hospital. So lots of times that includes doing a hospital formulary. And, you have folks making decisions about what drugs you're going to offer your patients based on being able to negotiate a good price for them. And lots of times, you guys, Dr. Hirsch and Dr. Fields, you're left out of those conversations because they become more of a financial conversation. So that's a whole nother angle. And then you also have to think about what you're saying, Dr. Hirsch, the outcomes. And as we know with drugs, lots of times we have our clinical trials and even devices, but you really don't know the outcomes till you get down the road and, measure the effectiveness of it. But lots of times that's not taken into consideration, and that thought process isn't weighed out.
Yeah, I completely, I think there's so many sides to this, and there are just, some things I can see it totally makes sense to negotiate, and it has to be negotiated, just like Dr. Field said. And perhaps the even better way is what Dr. Hirsch was just saying, and that's a great article. I'm going to have to go. I'll go. Thanks for posting that, Dr. Hirsch. It's in the chat box. That's a great idea because, if it does if it saves your life, of course the question there is, okay, so who should be paying for that? How should it be paid for? There's a part of me that says, well, the payer is the one with all the money. We call them payers. I call them, their job is not paying out. Their job is collecting premiums and paying out as little as possible. But I think since they're taking the risk and taking the money for it, they ought to be taking the risk more than the provider. So let's see. And Stephanie Daniels commenting that, while the law prevents CMS from negotiating with big pharma over drug prices, nothing should stop them from negotiating for a hip prosthesis. What stops them then, however, from negotiating for, body parts? I mean, if you can, it's not that there are so many of them on the market, right? Not on the black market perhaps, but not on the regular market. The price of if you have to have a heart transplant, the price of a heart is the price of a heart. If you want to budget one, I suppose you can go to the black market.
So since we're getting to the end, I'm going to be a little more philosophical. I'm going to put up another link to an article from the New York Times about drug shortages that we are now experiencing and how we're going to, at some point, we may need to start rationing these drugs. And someone just put up the question, what would I do for my family member if they were in that bed? Right. At some point, we're going to say, well, we only have 5 doses of this drug and we have 8 people who need it. Who's going to get it?
Yes.
Lots of.
Well, that's right. That's these lists. There's been television shows, all kinds of things for years about you get on a list to get a lung, right? Yeah. And there are some people who are able to, because they have a lot of money, they're able to find a way to get around that and move up the list.
But there's issues in the drug market because you can take a drug that's been around, isoproterenol, for a very, very long time, and it used to be about $10 a dose. It's now $1,000 a dose as a generic.
Wow. Because
there's only one manufacturer. So, there's a lot of movement of manufacturers in and sometimes out of the market, and when they leave, there's a big, huge consolidation where you're only left with one supplier, and it certainly becomes monopolistic.
Yeah, and Mary's commenting, it's the cheap drugs that are in shortage because they aren't profitable to the drug company, and that's sort of where I got to this point here. What happens if the budget pricing or the pricing being negotiated drives profits down so far that the technology firms don't want to do the research and development anymore. So that's another question. That's a market force. You can't force them to go do it unless somebody's going to pay for it. So it does become very difficult question. Well, I think that's about all we have time for today, but I thanks, Dr. Hirsch. Those are great articles. I got to go read those. Of course, I can't do that during the show, but thank you for putting them up. That looks like good reading. And it is it's something I think that people have to stay aware of, and people in our industry in particular, of course. So stay educated on it and stay up on what's happening. I think that there are things like there's commentary being asked for about like macro. We talked about that last week. These new payment plans. CMS is not giving you much time because there's like 99 questions on their survey, and they give you, it's a very complex set of questions. It's interesting. It's nice to know at least that they're thinking about it that deeply, that they come up with 99 questions about it. My problem is, what are their solutions going to be to those 99 questions, and are we going to be able to live with those or not? Are they going to hurt us or help us? And since it's the government, my sense is it's not going to be that much help. But it behooves us and people who listen to this show and who watch on Rack Relief and all these kinds of listservs. It behooves us to stay up on that and to stay up on where do you go to make comments. You're the people who know what to say. So it's not the public, although the public is open to make comments, but you guys are the ones who can make the comments. You're the ones who can make suggestions about, okay, that's not going to work. The thing you got to remember is you can't just say that's not going to work, because they're not going to listen very hard at that. You've got to give them an alternative. You've got to mention some other way. Okay, that's not going to work, but this could work, or I've got an idea that it's would be a little bit different. So that's what you've got to do on those comments. But stay up on those and make sure you participate. So I want to remind everybody we've got shows coming up in the next couple of weeks. We are doing what you call Operation Rethink. We're going to be talking about that in the future. We're putting together a series of shows about that. The idea that looking at a patient and thinking, can you do this outpatient? You really have to do this inpatient? Is it really necessary to do it inpatient? CMS doesn't want you to do it inpatient. They'd rather see you do it outpatient. They've made that pretty clear. So maybe we should stop fighting that and start thinking about ways to treat the patient and worry about that billing later. I realize that may not be everybody's idea or agree with me, but that's what I think we ought to be thinking about. Anyway, so we're working on a couple of shows coming up. The idea, can you predict denials? Well, we've got a tool that we're going to show you, and I'm going to make them show you, here's some things you can do without this tool that should help you predict denials. But Zermed is going to come on and do that on February 12th. Then I'm still working with Elizabeth Lampkin and the ACPA on showing ways to show return on investment that physician advisors and revenue cycle teams, what you do for the bottom line, because that's hard for you because you're not in finance. Well, Elizabeth Lampkin is a former CEO, and she's got a lot of thought about that. She's put together a tool, and we're going to have some people from American College of Physician Advisors come on and talk about that. That's in a few weeks. And then next week, February 5th, we have Dr. John Zellum from EHR is coming back to talk to us. He's been working on a presentation about cloning, and I'm talking about in medical records, not people or sheep. So that's next Friday. Be sure to come join us for that show, and we will. I'll be sending out emails about that this next week, so you can make sure that you don't miss the show. So thanks everyone for being on the show today. We're barely over the time limit. but we'll be back, like I said, live next Friday, February 5th. So watch for the announcements. Thanks to everybody for participating. We had a great chat room today. Special thanks to everybody there, and to Dr. Hirsch, and to Dr. Field, and, of course, to my loyal and faithful co-host, Sharon Easterling, who was always a great help on these shows. Many thanks also to our sponsors, the Health Law Partners, MedLinks Cost Containment. Chris, you were a contributor today. Thank you. Airlift Healthcare Solutions, Recovery Analytics, and the CCMA. They're the ones who make contributions that make these broadcasts possible, so you need to thank them. Listeners, watch for my emails about next week. Share the links to our show with your colleagues and friends, and I do want to share this one last thought with you about chasing your tail. You can either chase your tail or you can chase your dreams. You want to choose wisely. And my point is, look, even if you catch your tail, you're back where you started, right? So chase your dreams. I think that's what you ought to be doing. Don't worry about chasing your tail. Just keep up with the stuff as best you can. So thanks very much. We'll see you next time when it's finally Friday. Have a great weekend. Bye-bye. And I'm going to leave the chat room up for a little bit because there's another conversation going in there. I'll just leave it up. Thanks, everyone. Bye-bye.